Hello and welcome. This is the New York City Department of Health and Mental Hygiene's update on COVID-19 for New York City healthcare providers. Thank you for joining today's call. Please note that you have been placed in listen-only mode. If you have any questions during the presentation, please submit them via the Q&A portion of the WebEx, and we will address them as time allows. Joining us to provide an overview today is Dr. Didi Ray, Critical Care Planning Lead for Healthcare Systems Support for the agency's outbreak response, and Dr. Mila Harrison, Assistant Commissioner of the Bureau of Mental Health, will be presenting on behavioral health and suicide prevention during the COVID-19 pandemic. And with that, I will pass it off to Dr. Ray.
Thanks, everyone, and welcome back to our provider webinar. Can you advance the slide, please? So today we're going to start with our regular Where Are We Now updates, where we look at the global US and New York City data on COVID-19. Next, we're going to move to a clinical update. We'll also give you some other updates about guidance and recent papers in the literature. Then we're going to move to a special clinical update about cardiac manifestations in COVID and especially in recovery. And then Dr. Harrison is going to give us a very special talk on behavioral health and suicide prevention during the COVID-19 pandemic. There will be a poll at the end of the presentation, and of course there will be instructions on how to collect CME. And can you advance the slide, please? So overall, globally, incidence has leveled off. So we were seeing overall globally an increase in cases that had been persistent for several weeks. But although, as we always say, although when we represent average numbers, that often represents increases in some areas and stability or even decreases in other areas, and that is certainly the case. As we will see in the next slide. But within the US, again, daily counts are stable for most states, but are rising in some others. And we will see a map showing that as well. Several vaccine candidates, as you may have heard, are in phase 3 trials, and we will keep you updated on that as there is more information. Of course, in terms of policy, New York City continues a staged reopening with some in-person public school classes starting September 21st. You may have seen the news yesterday that some public school classes will not reopen on this date. And of course, this is, as you may have seen in our presentation last week, this is something that we are monitoring very closely and requires a data-driven, very nimble policy approach where we really are anticipating and responding to the nature of virus transmission when we think about what we're doing in schools. And can you advance the slide, please? So here are some of the maps I promised you, and these show, the first map shows cumulative cases worldwide. You can see certainly the hotspots that we are aware of throughout the world. And so this is what has happened since the beginning of the outbreak in the first map. The second map shows active cases. And so these are really recent cases. And you can see that there are some areas still lighting up in the US. You can see resurgence in areas of Europe and in India. And the overall burden of cases is 29 million cumulatively, and cumulatively almost 1,942,000 deaths. And can you advance the slide, please? This is a similar map for the United States, where you can see the cumulative cases. Larger dots on the first map represent a larger cumulative number of cases. You can see that, of course, New York City still represents a good portion of the cumulative cases in the country. However, there are other areas that have popped up. At one point when I was showing you this map, New York City was, sort of lonely big dot here. And unfortunately, you can see large dots in other places of the country, such as Florida. You can see it here in Texas and the Southwest, and then, of course, in California. Now, if you look at the recent map, although New York City has a large circle in the cumulative map, you can see that we are not lighting up much in terms of the current cases over the last week. And you can also see the same for the West Coast, but you do see spots of red popping up in the Midwest. And we have a total of 6.6 million cases cumulatively in the United States and just under 200,000 deaths. Can you advance the slide, please? And so here's a closer look at the cases in New York City. So as we can see, the bulk of our cases were earlier in March and April. I think we maybe don't need a graph to show us that, but you can see that the cases have decreased dramatically since that peak in March and April. Hospitalizations, of course, closely mirrored cases, especially at the beginning of the pandemic when testing was limited. And so we really were identifying mostly cases that were hospitalized. And then, of course, deaths lagged slowly behind, a couple weeks behind cases, as you would expect. But all of these are stable and low at this point. So cumulatively, we have over 234,000 cases in New York City, over 57,000 hospitalizations, and about 25,000 deaths with 24,000 deaths with 19,000 confirmed and 4,600 probable. And of course, there's a link on the slides to our data page, which is, contains a lot of really excellent resources. The slides will be available after the webinar on our provider webpage, and I encourage you to check that out. Can you advance the slide, please? So this graph shows another way of looking at the data that I showed you above, and this really spotlights the recent trends, and you can see that our weekly case rate, there has been an increase of 3.6%, but really that tells me that the numbers are staying relatively stable. The decrease in deaths, I think, has to be taken with a grain of salt because sometimes deaths take a little bit of time to report. And can you advance the slide, please? So here's more data, which again, all of these are available on our data page, but that show breakdowns of case rates since the beginning of the pandemic in March. And as you can see, the age groups of COVID-19, COVID-19 cases are most commonly identified in persons older than 75. But you can see that there is quite a bit of, I think this is a very staggered line at the beginning of the pandemic, and now you can see some of the later ages are flattening out a little bit, and that is likely because persons who are older are likelier to have severe symptoms, and of course, when we were only testing people with severe symptoms, that would influence how our graph looks. Race and ethnicity, you can see higher case rates among Black and Hispanic Latino populations relative to white and Asian Pacific Islander populations. And then, of course, by borough, you can see that the Bronx has edged out other boroughs, and of course, these are rates, and so this is per population, not a total count, but the Bronx has the highest case rate. And can you advance the slide, please? So just a reminder, it is September, and it is the time that we start talking about flu shots. Unfortunately, the flu does not go away just because there's another virus that we're worrying about. Influenza activity in New York City often starts in October and peaks in February. This is an especially important year for flu vaccination since there is evidence of co-infection with flu and COVID-19. And of course, it makes your jobs harder, all of our jobs harder, as clinicians and symptoms often look very similar between the flu and COVID-19. And of course, a respiratory illness is a respiratory illness. And so this is just a reminder to encourage your patients who are eligible to get a flu vaccine. To refresh your memory, we suggest that you offer vaccination to all persons over 6 months of age, and especially those persons at high risk. You can look at the list of what makes a person high risk for influenza. These are slightly different from the COVID-19 high risk factors, but we also recommend flu vaccination for persons at risk for COVID-19. And again, that list is updated as we learn more about the presentations of COVID-19, but please check those out on the website. So vaccination, under Vaccines for Children has started. So please order now if you haven't already. And we do have information on free immunization clinics. The website is listed on the page. I encourage you to check that out after the presentation is posted on the provider website. And can you advance the slide, please? So, as we've been talking about, as we have discussed for the last several weeks, the question of transmission dynamics associated with children, what is the nature of COVID transmission, and severity and course in children is a question that we continue to look for answers on. And so we have a couple of updates from the literature that are recent since our last presentation. And the first talks about the transmission dynamics of outbreaks associated with child care facilities. So in this study, which was located in Utah child care facilities, there's a retrospective review of contact tracing from three separate clusters that were identified in child care facilities. And overall, they did note that transmission occurred, via contact with children. So there was transmission associated with that, and that was a question that we had discussed, and that we really weren't sure about very early in the pandemic. But there are a couple important factors that we can surmise from the details of these cases. I encourage you to check out the study. But one of them is that 2 clusters were traced to staff members who attended work, although they were exposed to household members who were ill with COVID-like symptoms, rather than isolating or staying at home. And so overall, of the 184 contacts identified, 31 developed COVID-19. And I think it's useful to know that 12 children acquired COVID-19 in the child care facility, and they did not show symptoms. And so there was, since they were not aware of their exposure to COVID-19, they didn't isolate, but they were able to transmit the virus, and this is an important point. 25% of the non-facility contact, so people outside of the child care facility, were exposed. So 2 of the 3 children who were completely asymptomatic did transmit the virus. And there was even an 8-month-old child who transmitted the virus to both parents. In fact, one of those parents required hospitalization. Can you advance the slide, please? And so we can think about, what this suggests to us. And one is that it does seem to show that young children, and whether or not they have symptoms, can transmit COVID-19 back to their households and outside of the facility. Now, testing and widespread testing and of persons with confirmed COVID-19, testing the context of known exposures may actually play a role in preventing spread to household contacts. And of course, as this retrospective study, although this retrospective study does show there can be transmission outside the facility from asymptomatic children, it doesn't actually assess whether this transmission was the key driver of the outbreak. And so what the overall consequences in terms of population level transmission are is still something that requires investigation. And can you advance the slide, please? A second study, again, also looking at persons under 21 years, talks about death as the most severe outcome from COVID-19. And this is a large study compiled by the CDC looking at jurisdictions across the country and all deaths associated with SARS-CoV-2 infection in persons under 21 years. And the period of observation was February through July. And can you advance the slide, please? And so here we have a table with some of the characteristics of those persons under 21 who died across the country. You can see a male predominance. We'll talk a little bit about the breakdown using the race breakdown using demographic data. And of course, we looked at underlying conditions. And of course, another key feature is where the location of death was. Was it at home or the emergency department, indicating perhaps that if care had been initiated earlier, that the outcome might have changed, and that this shows that persons either never presented to healthcare or presented to healthcare shortly before they died. And can you advance the slide, please? So as we can see from that table, an important factor is that most of these persons under 21 had at least one underlying condition. This includes asthma, and the association between asthma and COVID-19 morbidity is something that's still being investigated. We've discussed obesity, also neurologic developmental disabilities, and cardiovascular conditions. And so that also shows you that 25% of persons under 21 did not have a noted underlying condition. So it is, while the underlying condition probably does modify the course of disease, it is not necessary. It's not necessary for a child to have severe, deadly COVID-19. It's not necessary for them to have an underlying condition. Then the next point is that persons aged 18 to 20 years accounted for nearly half of the deaths. And so they, of course, did not account for half of the infections of COVID-19. And so this is a disproportionate number of deaths. And so it is absolutely important to offer developmentally appropriate follow-up for people in this age group who develop COVID-19. The other point is about out-of-hospital deaths. And so while infants and persons, while infants were not, the most common group listed, we can see that infants and persons aged 14 to 20 years comprised a large, or had a large percentage of those died out of hospital. And although children in general are more likely to have mild COVID compared to adults, I would say that it's not they're not safe, and so it is important to pay special attention. And one of the other very critical findings of this study was that Hispanic, Black, and American Indian or Alaska Native persons, although they make up 41% overall of the U.S. population under 21, they accounted for a disproportionate amount, or 75% of deaths in this age group, and this is another feature of the health disparities and health inequities that we are seeing related to COVID-19. And can you advance the slide, please? So now we have a clinical update on cardiac injury and recovery in COVID-19. Advance the slide, please. So we have discussed this before in this presentation, but cardiac injury does occur, is a common feature among patients with severe COVID-19 or patients who are hospitalized. And so here we discuss a retrospective study from New York City of almost 3,000 patients hospitalized with COVID-19 in the Mount Sinai healthcare system. And in a lot of the studies I'm going to talk about here, we often measure, there are a couple of different ways we measure cardiac function. One of them is through an actual functional analysis where we look at how much the heart is pumping. But there are more and more biomarkers of cardiac injury and cardiac imaging that we're trying to use. And so in this study, myocardial injury or injury to the heart muscle was assessed using an elevated troponin I, which is a lab study looking at an internal component of cardiac cells. And so myocardial injury in this 36% was associated with worse outcomes, including intubation and death, but that was independent of the history of cardiovascular disease and other factors. And in fact, this troponin was a less sensitive indicator for poor outcome in persons with existing cardiovascular injury, suggesting that there was an independent cardiovascular contribution related to COVID-19. So there are a couple of studies about persons with less severe COVID-19 and their course after they have apparent functional recovery. And the studies I'm citing below here, look at cardiac MRI or cardiac magnetic resonance, cardiac magnetic resonance imaging. And this allows for a very detailed imaging appearance of the heart, a look inside the heart, if you would like to call it that. And so one study you may have heard about was a large study in Germany where they looked at patients after they had apparent functional recovery from COVID-19, at least with respect to their cardiac symptoms. And then these patients all underwent cardiac magnetic resonance imaging, and they actually found cardiac involvement in 78%. So 78% of these patients still showed some evidence of cardiac injury, and actually in 60%, there was ongoing myocardial inflammation, suggesting that at the molecular level, the pathology of the cardiac pathology of COVID-19 was still going on despite the fact that the patients were recovered. And this was not only in severe patients, rather it was independent of comorbidities, the severity and course of COVID-19, and even the time from original diagnosis. So there is no indication that this is just a long persisting inflammation and that it would drop off after a period of time, at least within the subacute period that the study looked at. I believe it was 11 to 53 days was the range. Another study, looked at patients who were really, of course, the study of 100 people looked at patients with different levels of severity. So some had mild symptoms, some had Some had severe symptoms, but that did not appear to impact the myocardial inflammation. So another study, which we'll discuss a little bit later, additionally, looked at college athletes who were looking for clearance for return to competition after contracting and recovering from COVID-19. All of them had experienced mild or no symptoms. However, 15% had indication of myocarditis, again, even though they had recovered from COVID-19 and all had mild or no symptoms. And then, so this myocarditis means evidence of ongoing myocarditis, and 31% had evidence of prior myocardial injury. And there are also two similar studies in China and Hong Kong. And then again, some are in mild cases and some are in severe cases, but both of them found, using imaging, although there had been functional recovery in most of them, that 50% of patients showed evidence of myocardial injury and in many cases, ongoing inflammation. And can you advance the slide, please? So again, if we're talking about recovery from COVID, cardiac symptoms after recovery from COVID-19, we can, of course, discuss cardiac injury in multi-system inflammatory syndrome in children. This is, as you may recall, a multi-system involvement of inflammatory syndrome, so involving multiple organ systems, but it appears several weeks after SARS-CoV infection. We have currently 226 reported cases in New York City, and of course, as you may have heard, a very, very common feature of MIS-C is that it involves possible cardiac involvement. There are a lot of ways, the common cardiac findings. One of the most commonly reported cardiac findings is, of course, depression of left ventricular function. So that is a functional outcome, meaning the heart is not pumping as well. I think one of the issues in all of these studies, especially in assessing recovery, is that there are lots of different ways that cardiac function or cardiac injury are measured. And of course, the lab markers of brain natriuretic peptide and pro-BNP, as well as troponin I. Here, we just discussed a study where, again, they looked in detail at the echocardiographic findings in a series of 28 patients. And again, these are patients who had all recovered from MIS-C, had recovered from COVID and were diagnosed with MIS-C. And they noticed in this very detailed study, although the patients had complete functional recovery, the echocardiogram suggested left ventricular systolic and diastolic function, and the patients that recovered, even though their systolic function and their ejection fraction recovered, the diastolic dysfunction was often persistent, even after complete recovery and discharge from the hospital. And so the moral of that story is that myocarditis may be persistent even after apparent recovery. Of course, as a reminder, please call the provider access line to report any suspected MIS-C cases, and that's 866-692-3641. Advance the slide, please. So, what is happening? What is going on with cardiac injury and COVID? And of course, as I feel like I say in every one of these clinical updates, we don't really know, but there are a couple hypotheses. So one is just that general inflammation or generalized inflammatory response, or even a specific inflammatory response related, to proteins or antigens that have traveled to the heart may cause cardiac injury. A subset of the inflammation category is, of course, in MIS-C, there is a possibility that this represents a post-acute immune reaction to some aspect of COVID-19. course, there's the idea of hypoxic stress. If the lungs are involved, then that creates demand on the heart. Thrombosis and endothelial dysfunction, so both large and small clotting. We've discussed clotting and how COVID-19 is often accompanied by a hypercoagulable state, and of course the idea of direct viral invasion, because several cardiac cells do exhibit the ACE2 receptor, and so are the viruses going directly into the heart. And can you advance the slide, please? So here we just highlight a paper that looks at in vitro and actual human autopsy samples. And so in this study, they treated cardiac stem cells of lots of different lines of cardiac stem cells with SARS-CoV-2 in the lab, and did detailed immunofluorescence, staining, and electron microscopy examinations of these cells, and then additionally examined autopsy specimens from cardiac samples of patients who had died of COVID-19. And this is very interesting. What you can see in this slide is that actually the myocardial cells, which are generally contain striated bundles of cardiac muscle filaments, that the virus, in a time-dependent fashion, created precise ordered disruptions to the sarcomeric structure and complete dissolution of the cardiac contractile machinery. What you can see is these long lines in the 24-hour diagram that you see throughout the cardiac cell are kind of chopped up, and they're chopped up in similar sized pieces at similar points in the cardiac cells. And while you can see that in the 24 hours, some of these normal appearing cell structures, you can imagine how they would work in a contractile mechanism. And of course, that contractile mechanism is completely disrupted in the second slide. A couple interesting pieces from this is that heat-killed virus did not generate disruption. So that goes against the idea that this is just a pure immune reaction. However, there was an observed asynchrony between viral replication and myofibrillar disruption, and so this indicates that viruses do enter the cells, but it's not necessarily the active virus replication that is causing, or at the time that the virus is most actively reproducing, that this injury is occurring. And that's something to think about when we think about, when we think about a clinical perspective of persons who have a mild clinical course and then develop cardiac symptoms or have cardiac injury subsequently. And of course, why haven't we seen this before? The normal cells the normal stain that we look at to look at cardiac cells, which is a hematoxylin eosin stain, probably doesn't reveal this pattern very easily, and so it requires special staining. And can you advance the slide, please? So what does this mean? What should we do about this? It looks like there is molecular evidence and there is also clinical evidence that we should be thinking about the heart in patients, even young, healthy patients with mild disease or no symptoms, who have recovered from COVID-19. And at the moment, this is all at the physician's discretion. There are no routine recommendations for cardiac screening and surveillance. However, this is always something to keep in the back of your mind, and you can maintain a high suspicion of cardiac injury in patients who develop symptoms after recovering from COVID-19, especially if these persons did not have any cardiac symptoms prior. Of course, the study I discussed earlier about cardiac MRI in patients trying to return to competitive sports. We don't know. We know that even in young, apparently healthy persons, that there is some value of cardiac surveillance or surveillance for cardiac conditions. And so, anyone who might be at particular risk or even particularly active patients, keep this in the back of your mind when you do their evaluation. And can you advance the slide, please? Here, and of course, this is going to be very hard for you to read on your screens. I encourage you to review it after. But here is a study where or an article where they propose a return to work or return to play algorithm for athletes and highly active people recovering from COVID-19. And, while this is certainly not applicable to every one of your patients, I think it does a really good illustration of the different methodologies you can use to assess cardiac function or ongoing cardiac inflammation in patients. And it really provides an example of a thought process of what you would go through in a cardiac evaluation. One of the features that is not here is one that we've discussed extensively in the presentation, which is cardiac MRI or cardiac magnetic resonance imaging. And, it is very good at sensing this ongoing these findings that suggest ongoing inflammation, even though patients seem functionally okay. But that is also another imaging study that you might consider in your evaluation of cardiac patients. And finally, we have a whole list of resources for you here. Again, I encourage you to check those out when the slides are up on our provider page. And advance the slide once more, please. And now I'd like to turn it over to Dr. Harrison to talk about the very important topic of behavioral health and suicide prevention during the COVID-19 pandemic.
Great. Good afternoon. Thank you so much, Dr. Ray, and thank you all for inviting me to participate in this presentation. Next slide, please. So what we're going to cover in the next, 20 or so minutes, I will try to speak quickly, and slides will be available after, is epidemiology as it relates to suicide. We're going to talk about actually some data and information about the behavioral health impact of COVID-19 and suicide prevention as well. Next slide. So I'm going to start big picture, U.S. And New York City comparison of suicide data. What this graph is looking at is 2007 to 2016 suicide rates for New York City compared to the U.S. If you look at the NYC overall rate, it is a solid black line, sort of toward the bottom of the graph. You can see that it is much lower than the U.S. overall suicide rates, which is a dotted black line that's higher up on the screen. I also want to point out to you that there's separate rates here for men and women. The men's rate is a solid blue line, which has most recently, if you compare 2016 to 2007, we have not seen an increase. It had increased a little bit in like 2013. It has come back down and is actually a bit lower than it was in 2007. That contrasts to the rate in women in New York City, which is the bottom red line, the solid red line, which is lower than men. The women's rate across the country is always lower than the rate for men. But what I want to point out here is the difference when you look at 2016 compared to 2007, where the rate for women is higher than the rate it was in 2007. So the rate for women in 2016 was 3.5 per 100,000 in New York City, and in 2.7 was 2.9 per 100,000. So it's a slight increase, and it's been slightly increasing over the years. then specifically, those rates I just showed you for all ages. If you pull out just the 10 to 24-year-olds, this is again a map of a country. This is data hot off the presses, just came out from the National Center for Health Statistics, that shows rates at a state level compared to each other. And you can see that New York State, which is a green color, has a rate of less than 10 per 100,000, which is in the lower range. You can see where rates are higher across the country. What I also want to tell you, you cannot see it in the slide, but what this research showed, what this paper showed, is they also compared 2007 to 2018 data, and across the country, for the most part, we have been seeing increases in rates among the 10 to 24-year-old group. The state of New York overall saw an increase if you combine 2007 through 9, 3 years combined, and combine 2016 to 18, 3 years combined, and look at those comparatively. The rates have increased by about 43.9% in New York State. And so it is concerning that, overall rates in the U.S. are going up. Overall in New York State, the rates in this age group are going up, and overall in New York City, the rates for women are going up. Next slide, please. So New York City, if we look at 2016, we do have some more recent data. I will show it to you in the next slide, actually. But if you look at 2016 by age group, we see and have continued to see the highest rates of suicide in the 45 to 64-year-old age group, which has a rate of 9.2 per 100,000. And again, this is a pretty consistent finding. In 2016, in that same similar group I just showed you, the younger age, we see the 15 to 24-year-old age group. Suicide was the third leading cause of death in New York City. Next slide. And then again, New York City, if you look at 2008 to 2017, this slide's a little hard to interpret because lines are going up and down. What I just want to point out is what I just said about the rate for the 45 to 64-year group has a most recent rate of 9.7 per 100,000. It is the highest rate when we break it out to the 25 and up groups. And just to share with you,
Dr. Harrison, I'm so sorry, your sound is going out.
Okay.
That's sounding a little better right now. Okay. Sorry to interrupt.
That's fine. I'm trying to hold the mic to my mouth. If you guys can't hear me again, I can try to unplug and just speak into my computer if that's easier. I'll hold the mic and hopefully that will help. Just wanted to show that on this particular graph, the 25 to 44-year-old group had been lower than the older group, the 65 plus group, but it surpassed it in the 2017 year. And again, some of these have gone up and down over time, but I wanted to share this with you. Next slide. So you can keep going and talk about the behavioral health impact of COVID. In general, what we're seeing, what we know from prior traumatic events that most people who experience a traumatic event will be resilient and will not develop long-term mental health challenges. However, we do know that traumatic events and past crises, various natural disasters, epidemics, civil unrest, financial recessions impact mental health and have been associated with increases in depression, in anxiety, in post-traumatic stress disorder, in general psychological distress. And we know that lower income and less wealth are associated with greater burdens of mental illness. Next slide. So if we were to take what we know from prior disasters and apply it to this pandemic, we can anticipate, and we're seeing it, that most people may experience reactions, distress kinds of reactions, difficulty sleeping or less sense of safety, irritability or anger. Those are not necessarily long-lasting kinds of reactions. I think most people will admit early on there was lots of those distress reactions people were experiencing. We know that some people are likely to have increased health risk behaviors, and those kinds of behaviors are misuse of alcohol or tobacco or prescription drugs, for instance. And again, we will not see this in everybody, but we might see these kinds of behaviors. And behaviors that are involving health-risky kinds of behaviors may also end up being seen in primary care practice offices or even involving law enforcement. So these folks may show up in other healthcare and other settings. We know that a smaller proportion of people will have psychiatric disorders, and it could be that people with existing mental health disorders have exacerbations. It could be new onset of symptoms, and I had mentioned these already: depression and PTSD, persistent complex bereavement kinds of reactions. That's something that can be seen. However, this blue box on the right, again, most people are resilient, and we will not see lasting issues. They will be able to leverage their strengths and resources and connections to show resiliency. So I'm going to take us to the next slide, please. I want to pivot to talk about the impact of structural racism on mental health specifically. So we know we've been talking about people being impacted by structural racism, poverty, and other systems of oppression, and we see disproportionately high rates of illness and death and socioeconomic difficulties. And we know that that also compounds health and mental health burdens from the same kinds of issues. So next slide, I'm going to show you some data. From New York City, from a survey we did in 2017, where we asked people to tell us about symptoms of serious psychological distress. We're using something called the K6, the Kessler-6. It's a measure that correlates with psychological distress. And we asked about experience of racism, for instance. So if you look at the leftmost part of the slide, we found that people who experience racism always, a lot, or some of the time had 3 times the rate of serious psychological distress compared to people who did not experience racism, or little or not at all. We similarly see for people who tell us that they are living in unsafe neighborhoods, this is the rightmost part of the slide, also 3 times the rate, 15% prevalence of serious psychological distress compared to people who say they live in safe neighborhoods, where only 5% of the respondents endorse symptoms of serious psychological distress. And for other kinds of social determinants, if someone doesn't have enough money for food, for instance, they're telling us that in this survey, they have more than 5 times the rate of serious psychological distress. This is the 25% number compared to the 4% who say that they have enough money for food. And similarly for rent, enough money for rent, it's about 4 times the rate of serious psychological distress. Next slide. If we look at also very recent data that's come out of the CDC from a survey that they did of over 5,000 adults in the United States, where they asked about a period during this week in June, if they experienced anxiety, depression, or increased use of substances, or seriously considered suicide in the prior 30 days as it relates to COVID. And you can see here the rates of anxiety disorders, depressive disorders, at least by symptoms, and seriously considered suicide. This is the second from the right bar at 11%. When they looked at these responses compared to responses from earlier in second quarter of 2019, for instance, so from a prior pre-COVID time, we see much higher rates again, rates that are about 3 or so times higher than they were from other times these questions were asked of the population. From this CDC survey, we also note that certain populations had greater mental health burden, and this was seen in younger adults, Latinx individuals, Black individuals, essential workers, unpaid caregivers for adults, and those who were receiving treatment for pre-existing psychiatric conditions. Next slide. This actually is similar to what I just said. This shows 2 different studies, one recent, which is the lighter greenish colored bar. This is rates of depression by level of severity, where we see higher levels of people, higher percent of people saying they have depressive symptoms that are either mild, moderate, moderately severe, or severe, compared to earlier surveys asking the same questions of a different group of individuals. So again, higher rates of depression following COVID compared to pre-COVID. Next slide. And again, if we pull us back to New York City, we frequently talk about NYC Well, which is our call, text, and chat line. It's a crisis line and an information and referral line. This graph is comparing same month last year. The blue bars are 2019 answered volume, and the orange bars are 2020 answered volume. And you can see we have the percent increase over the orange bars, where from April and continuing, we have a much higher percent of answered responses by our NYC Well call center. Most of the calls, when people are calling NYC Well, are for brief support and counseling. Lots of folks are looking for information and referrals. A smaller percentage are individuals in crisis, yet we want to be there for them. So let's move to suicide prevention. You can get to the next slide. So suicide is preventable, and yet it's complex. There's rarely one single cause for somebody to consider suicide, die by suicide. We do know from various kinds of data and surveys that behavioral health challenges such as depression, anxiety, stress, grief, or changes in substance use may be contributing factors. And we also know that identifying behavioral health challenges, knowing somebody has thoughts of suicide and other kinds of suicide risk factors, and then the subsequent referral to care can reduce a person's suicide risk. Next slide. I'll probably go somewhat quickly through these next slides because there's a lot of lists, and I don't think it's going to be meaningful for me to read these lists. I will tell you what's here and know that these will be posted after, and also let you know that these are available not just on the CDC website, which is listed on the bottom, but in documents, guidance documents we've put out on our own website at the Department of Health and Mental Hygiene. So again, while suicide is rarely caused by a single factor, there can be factors we see if you look over time across individuals, and that includes things like a family history of suicide, a previous suicide attempt in an individual, a history of mental health challenges, a history of alcohol and substance use. So I'm showing you some of these just so you can have them and see what these look like. The next slide, please. Again, lots of other risk factors. Sometimes suicide can cluster across individuals. Varying cultural or religious beliefs may also indicate that somebody's more likely to die by suicide. Loss in particular, relationship loss, other social losses, work loss, financial loss is also a potential risk factor. And I think in our current times, we have to be aware of these kinds of situations. Next slide. So what could be protective? And I have to say, as I'm talking about these risks and protective factors, that there are differences across varying racial, ethnic, cultural, religious groups, even regional groups to consider. And again, there is not a one-size-fits-all either for risks or protective factors. So we're giving you as much information as we have about the issue. So some protective factors, if somebody is connected to care, can be protective. Mental health care, physical health care, care for substance use or substance misuse as well. Having access to clinical interventions can be protective. Having family and community supports in the sense of connectedness is also really critical. And then there's some other ideas about skills in conflict resolution and problem solving can be useful too. Next slide. So mindful of time, the suicide warning signs, I think these, again, you can see some of the ones we almost always talk about is related to giving away possessions and saying goodbye to friends and family. The ones about avoiding friends and family and losing interest may not be as specific, but something, you know, to find more out about if you're hearing about these things. Next slide. So how to recognize behavioral health challenges in patients, you have to ask. You have to find out how people are doing emotionally, mentally, physically. You can ask them, you know, or say in the last 6 or so months since the start of the pandemic, how are you feeling? Have you noticed any changes in your mood or how you think or your use of substances, for instance? And again, you don't want to ask it all in one question, otherwise you might not get a response. You have to be thoughtful and be willing to hear the answers. Next slide. So it's also important to normalize, validate somebody's feelings and reactions. And we've done other presentations about this and have lots of materials about this as well, that it is not uncommon, as I showed you earlier, to have various symptoms of anxiety or stress or trouble sleeping as a response. So, you know, you have to be able to see that, help patients see this, and help them actually cope if that's needed. And again, we have information about this on our website. Next slide. So what's also important is, as you're finding out how people are feeling, is, and people in primary care may be doing this already, but it's also to ask them more specifically about how they're functioning, how they're doing, and if they're having trouble functioning at work or caring for their family or attending to their own needs, you of course need to be more concerned. So the next slide is just the Generalized Anxiety Disorder 2 question and the Patient Health Questionnaire 2. Next slide. For depression, it's the GAD-2 and the PHQ-2, and there's a little guide to scoring at the bottom. You can ask these questions. Again, they're over the last 2 weeks. How often have you been bothered by the following problems? So I'm not going to read them because it looks like we have like 60 seconds left. So let me get us through. Next slide. Again, the idea is to refer if you're concerned about somebody. Next slide. And NYC Well is available not just for referral, certainly for referral, but also because there are apps on the NYC Well site that you can offer up for free for people to access, which can help them with their own self-help around mood or anxiety. And I think next slide I want to share with you, which offers services and supports around food and finances and immigration issues. And then the last 2 slides are around healthcare workers and how to take care of yourself. We know there is an increased burden on healthcare workers, and it's important to take care of yourself. I won't read through these. And then the next slide is how to take care of your colleagues. Next slide, which is just, really thinking about your colleagues and what their needs might be. And again, how to normalize some of the things that people are feeling, and to be there for each other and to seek help when help is needed. So I believe I am out of time, and again, these slides will be posted, and I'm going to turn it back to the other folks.
I know we're at 2:01, but maybe we can do, we only really have one question from the box. So can you do one question, Dr. Harrison?
Sure.
So we had a question about neuropsychiatric symptoms after, in COVID recovery, and how to kind of parse that out or approach the neurological aspects of recovery, maybe even post-acute care recovery, and these sort of pervasive psychological symptoms that we're seeing in people who have and have not contracted COVID.
So that's a fantastic question. And I think, there is so much we are still learning about the impact of COVID. I mean, you just heard about cardiac impact. I think there has been somewhat less out there on the neuropsychiatric symptoms, although it clearly is being spoken about. And again, I don't think there's one easy answer to this question, again, because there's a lot that we're still learning. I think if people are seeing patients where, are these COVID-related symptoms, are these, new onset of mental health related symptoms, certainly referrals, depending on what these symptoms are, either through to psychiatry or neurology for assessments is going to be, I think, useful and critical. And there's a lot of literature on follow-up from ICU care in general, not just specific to COVID. There are a lot of challenges when somebody's been in an ICU for any length of time on their mental health and ability to cope. So, there's a wide range of kinds of disorders and tools that can be used. But again, I think seeking out additional resources and referrals for that's probably the best bet, again, because there's just so much we do not know at this time about the potential for impact on the brain and the neuropsychiatric physiology there. It's a great question.
I think we're 3 minutes over, so I think that's all we have time for. But Allison, do you want to close us out? And thank you, Dr. Harrison.
Sure. Yeah, thank you everyone again for joining us. Our next webinar will be on Friday, October 2nd from 1 to 2 p.m. That's 2 weeks from now, so we're still on a bi-weekly schedule. We thank you to those of you who were able to fill out that poll that was available for the last 5 minutes. And we also will follow up the email with the survey for those who are seeking CME credit through New York City Health and Hospitals. And we will update the provider page on our website with these slides, as well as a recording of the webinar and registration information for our next event. And we thank you again for joining us.